When people are depressed and they have unhealthy relationship, they're going through a divorce, their finances, their kiddos are not listening to them. The in-laws seem to be controlling. They can't seem to get ahead in work because their bosses are being jerks to them. Life shows up in your nervous system and displayed in your body. Statistical analysis shows that people who continue to believe that the reason they hurt is because of structural nerves or tissue issues tend not to get better.
I want to introduce you today to Dr. Les Aria, who's our lead pain psychologist. My interview with Dr. Aria today is to get a little bit more information about his background, how he ended up in this specialty area, and what even is the specialty area of pain psychology.
Thank you for saying yes to doing this. I know you have a very busy schedule and it's the weekend, so I really appreciate your time.
Of course. It's my pleasure.
Let's dive in, Dr. Les.
Yeah, let's go and get that out.
So my first curious question about you. You were raised in California, correct?
Correct.
Where you are now. Okay. So were you one of those kids that knew from an early age that you wanted to be a psychologist? Like, at what point did you know you wanted to take it all the way through the education to get your PhD?
Yeah, I did not know. I actually just wanted to go out and have fun. So I did well in high school, but had no clear plans except what my parents told me, mainly my mom. She wanted me to be a dentist. And my dad wanted me to go to Annapolis, which is the Naval Academy. So everyone had plans for me. It was when I was thinking my junior year, I better really do something about this. I was studying psychology with a minor in gerontology. And I figured I better do something about this, maybe law school, medical school, dental school. Didn't quite know until one day I was walking out of class and I asked one of my professors, and I was doing pretty well in school. I put myself through school selling shoes at JCPenney's. And so that's how I put myself through school. Since I didn't have a clear plan, my parents wanted me to learn the rule of you need to grow up and take responsibility. And so, well, they taught me a good lesson. I asked the professor as I was walking out one day, and I really did well in the midterm. And I said, I think I want to get my PhD and be a psychologist. And she stopped me and looked me in the eye and said, it's too difficult, just get a job.
Wow. Wow.
And that was my impetus. When someone says no, I say yes in my head. Don't know what that is about. It is quite rigorous. However, I made it through. So
you made it through. Now, did you plan to teach, or did you want to be a clinician, or end up doing both?
It's great. I wanted to do both, but fell in love with the clinical work. And I realized that the clinical work, I had kind of a knack for it, I guess. It just kind of grew on me. And all of a sudden I started to fall in love with the clinical aspect. And that's where I just focused on that. And specifically, just to be clear, I focused mainly on health. And so the training I received was basically what we call health psychology. And health psychology is very different from clinical psychology, where health psychology is about how can we improve someone's mental and physical health. Yeah, there are many, many aspects of it. You can be a cardio psychologist, an onco-psychologist, or psycho-onco-psychologist, which is a psychologist who works with cancer patients. So there are many, many subtypes. And one of the other subtype would be pain. And but I will say this through. I still remember this. This is my first year, I think. End of my first year, and I was doing a clerkship, and that means you just shadow people and maybe get a feel for where you might want to go. I remember attending this pain clinic, and the clinician who was there was anxious because the patient who had chronic pain picked up the stool and threw it across the room and demanded for the opioids. And at that point, I remember looking down and taking some note. Don't want to work with this population. And that's what I thought. So I often say never.
So the patient throws the stool and you're like, forget it, pain's not for me. Yeah. What happened that turned you around?
Yeah, great question. So I decided to pursue all that, decided not to do pain. And I'm like, don't want that. I decided I had a love for the brain and I also have a knack for neuroanatomy. So it comes natural to me, I guess maybe because I love the brain. And so I decided to pursue a neuropsychology route. And what a neuropsychologist does is they do lots of assessments, so clinical assessments, testing, and they work with different populations, like anywhere from strokes to spinal cord injuries, brain injury. They do lots of assessments and any other, many different things. So I was pursuing like brain injury, stroke injury to be an expert in that, to evaluate after someone has an injury, what are their cognitive abilities. In that pursuit, as I was getting, now mind you, I've completed my doctorate. I'm in my, what we call a fellowship, which is specialization. And in the middle of it, the middle of the year, I told my supervisor who was supervising me, said, "You seem to have a knack for helping pain patients get better." And I'm like, "I do?" And she said, "Yeah, you seem to pile up a lot of them. Stroke pain, thalamic stroke, I seem to kind of work really well. And people with chronic low back pain after brain injuries." And I started to kind of enjoy that. And then it was when I started to notice some of my patients were getting better. And then I just went full on and just started to focus on chronic pain and just fell in love with it. So never say never.
But you
Yeah.
seem to use in your line here in your specialty, which I'm learning about now working with you at Menda Health, is PRT, or pain reprocessing therapy.
Yeah, I think a lot of us were doing PRT even before it became a name brand. And
Okay.
it's a branding. And in the sense that, and that's attributed to Alan Gordon, Howard Schubiner, Yoni Ashar, and several others. And so PRT is basically a way, and let me just define it for the public. PRT is nothing more than learning to reframe pain sensations as being safe. Reframing pain sensations as being safe. That's PRT. That's the whole focus. And many of us were doing mind-body work already based on, and this Alan Gordon, Schubiner, Yoni Ashar, all of us, David Hanscom, David Clark, a lot of us around the world, we were following someone's guiding post called John Sarno. So Dr. John Sarno was a physiatrist, that's a spine physical medicine doctor in New York, who's passed away many decades now. And he started this off about a good 50 to 60 years now, and saying that when people have spine issues or pain issues, chronic pain issues, it was less about the structural nerves and tissue issues. So the issue was not in the tissue. The issue was really emotions in the brain. Yes, correct. So that's where this all comes from. And with the recent seminal work of Yoni Ashar, Alan Gordon, Howard Schubiner, who did a study and published it in the JAMA, Journal of American Medical Association, in 2021, September, showed the world for the first time that mind-body interventions, hence PRT, pain reprocessing therapy, can actually impact physical pain. And they showed before and after brain scans of 200 plus people, and out of that 67% became pain-free, or the pain was barely there, 0 out of 10 or 1 out of 10. And they recently went back and looked at the data, which is kind of cool. The data shows that when people have this full belief that their pain is caused by the brain and or mind-body syndrome and or nervous system, basically it's coming from a source that we can actually mitigate, we can actually influence, such as the nervous system, for example, is to keep it simple. They get better. People who continue to be possessed, like possessions, I have a saying, when people, just like possessions, we have cars and things and that we spend money on, just like we can be owned by possessions, we can be owned by our pain beliefs. And I often tell my patients is whatever you believe, believe it. But if it gives you life and you have an option to be able to get your life back, then you might want to ask yourself what stops you from not believing that this is the nervous system or the brain.
So playing devil's advocate here, how do you present this to someone, though, that does have a structural issue? Like, let's just say there is a herniated disc pressing on the nerve, they have sciatica going down their leg. I mean, that's a structural issue causing this nerve pain. Is maybe that not the type of person you would treat?
Yeah, great
this
question.
approach?
Yeah, no, I think we can get clearer here, and then we can talk about structural issues. Pain reprocessing therapy works best for those who have a mind-body concept. Pain reprocessing therapy works for people who have been cleared by physicians as not having anything infectious, cancerous, or anything dangerous in them. So
Okay.
that's one. So it works really well with that. However, there's a group of people who have been identified. Hey, my doctor said I have a herniated disc or multiple degenerative disc disease. But even then, when someone says, I have this fancy medical diagnosis, one of the things I often encourage them to do is please get clearance from your doctor to make sure that you don't have an infection, you don't have any cancer, or you don't have anything seriously going on. Because, well, my sciatica is serious. Yes, no, it is serious, but medically serious where it's going to kill you, it's going to harm you if we don't take immediate action. And once I get clearance from those three factors, I ask the physicians to do one more thing, ask the patients to ask the doctors who have herniated disc and all that fancy diagnosis. I ask them to ask the doctors this, am I clear to exercise? Am I clear to move? And 9 out of 10 times, if not 10 out of 10 times, yes, move, it's important. So when I get clearance, that's when I actually enter into treatment. So does this work? Yes, it does. PRT does work with people with fancy medical labels, but I want to have one caveat here, is that very often it's misconstrued, and I have a lot of my close friends, physical medicine doctors, spine doctors, and orthopedic surgeons. These are the guys I hang out with, and except with a bunch of other psychologists. But so I've got a small group of friends I hang out with, and I like teasing my physician friends. They often say, yeah, I said, why do you not tell them this could be coming from the brain or mind? He goes, because I'm not trained in it. And I said, well, you gave him a diagnosis of herniated disc, but is it really from the disc? Well, it shouldn't cause that amount of symptoms. So a lot of physicians often don't know, and they only know what they know. Here's the truth of the matter. There's very little correlation, very little, I didn't say 100%. So I would say about 80%, there's very little correlation between the diagnosis and the pathology. Very often, a lot of the patients I see with, L4 or S1 pain issues, they usually have pain somewhere else, or the pathology where the nerve goes from the spine to the legs. It doesn't quite follow the proper pathophysiological route. Basically, it should wrap around like a snake or come down a particular area. It does not follow that. That is an indicator that this is not just spine. Now, in my 20 years of doing this, I can say with confidence that fancy medical diagnoses, once you've done the medical merry-go-round, it might be time, and it would behoove someone not to try PRT, because most of the time, the structural issues and tissues issues are really not about anything damaged in them. It's about the brain that's shifted real estate in the brain from where it processed physical pain into the emotional part. And this is the part where most of my physical medicine doctors and surgeons don't quite get, because all they know is about the spine and what they were taught. But the brain dictates this. So when people have chronic pain more than 6 months, for example, their brain changes real estate from where they used to process emotions, where they used to process physical sensations. It moves it into the emotional part of the brain. You go from uptown to downtown. So from the parietal area, which is, just to get technical here, pain is often processed, especially when it's in acute and subacute, in the somatosensory SN1, S1, and S2, so the different brain parts. And pain is really processed all around the brain, but just to be technical and clear here, so to be reductionistic so we can follow this thought, is pain is processed usually up in this area. And then when it becomes from subacute to chronic, it shifts real estate into the emotional part of the brain called the limbic system.
Fascinating. So your ideal patient to treat is not an acute pain patient necessarily. You really like to treat them when they've moved into that 6-month or more space, or do you like to get them earlier?
Yeah, great question. When I was with a large health organization in Northern California for 20 years, one of the things I used to do was talk to the primary care physicians, the physical medicine, the physical therapist, anyone who'd see a patient between acute and subacute phases. And just for clarification here, anywhere from 0 days to 2 weeks might be acute, even 4 weeks might be pushing it. And then 4 weeks to about 12 weeks is about subacute. It varies. And I'm just being very general with this timeline. I talk to doctors when you are entering the 2nd month, maybe the 8th week of an injury, a slip, a fall, a car accident. You were lifting weights, you woke up one morning, it doesn't matter. You reached for a tissue on the ground and you heard a pop, and it doesn't matter how it happened. The question here would be is if it's prolonging past into the 2nd month, 8 weeks, 12 weeks. At this point, I usually tell them when they've tried all medical stuff and there's no cancer, there's no infection, and there's nothing seriously else that better accounts for their pain, send them to me. So ideally, I would love, and I wish for the world, medical health system to shift into catching people in the subacute phase, because it would save people their unnecessary suffering and the ridiculous amount of medical merry-go-round and allied health professionals they tend to seek. And if we accumulated it, it would be 50,000 to 100,000 plus in that 5 years. Now, I often see patients after 52 months. It's almost like 4 years and some change.
Whoa, yeah.
So, and have I treated someone with pain 25 years with low back pain and fibromyalgia? Yes, absolutely. This is the cool part. The brain is neuroplastic, it changes. So the old way of thinking, 20th century that is, of that, everything is static. If you have pain, you're screwed. No, 21st century, which what we're in, says that we actually have the ability to help people get better. However, if we keep using what I call Descartes' model, common sense model, I hurt because there's something damaged in me. Descartes was a philosopher, Rene Descartes, that is. The dude wasn't even a physician. And I did a presentation for the Psychophysiological Association recently. Check that out, PPD association.org, great website. I did a presentation for them and said this: Rene Descartes, the reason he separated mind and body is because in the 17th century, the Orthodox Christians in the 16th, 17th century would not allow any doctors to cut the body and examine it because they believed the soul was in the body and the mind was in the body. And if you did that, you couldn't go to heaven. So Rene Descartes comes around, who started to teach and write in medical schools and write papers and books. And he basically said, how can we advance medicine? And he basically said, the mind and body is separate. The mind is in the brain, is up here, and the body is separate. And that's what started in the 17th century, and medical schools till today teach that.
And so when I hear you talk about modern pain science, your work is based on modern pain science. You're distinguishing. I was going to ask the question is, what was the dated pain science? It sounds like the dated pain science is that the body and mind are separate.
Yes,
and the modern pain science is that the difference. Yeah.
Nailed it. That's exactly it. And they still teach this in medical school. Like, mind you, some of my colleagues who've been practicing medicine from 12 to 32 years, and they will tell you this. They never taught us this. They basically said, there's disease or something, let's try to focus on the symptom. And I do not focus on the symptom. I do not do pain management, just to be clear. I do not do management. I do retuning of the nervous system.
So when your patients come to you and they start talking about structural issues and spondylolisthesis and all these stenosis and all these different things, do you get them off of that? Is that part of it? It's like that we're going to kind of move the brain, we're going to shift the brain away from the structural issue that you've been told you have?
Yeah, it would be really invalidating. It's like someone who's anxious saying, stop being anxious, calm down. It's so invalidating.
They do have the issue. I mean, some of them, some don't, but some have been diagnosed with the structural issue. But if they're focusing on that, do you try to shift them away from that?
I do not.
Okay.
This is the cool part. The work that I do with my patients is that evidence will speak louder than anything else. And in part of the work that we do at the Menda program, we've created some guiding posts where we get people to convince themselves. Think about, I was trying to be convinced by my mom to be a dentist. And think about that. How does that work for anyone who's trying to convince you, like, I've got to sell you these 2 vacuum cleaners like a salesperson. You need it. You're like, no, I'm good. It's very offensive to try to convince someone, and that's not my job. People who are new into this PRT, pain reprocessing therapy, again, it's just a name brand, it's mind-body approach. Many of us have been doing this before it was even termed, but I love what Alan Gordon did, Schubiner and Yoni Ashar. What I want everyone to know is it's just that we want people to have that experience. I'll give you an example. Whenever someone has very severe sensations in their body, let's just take sciatica, for example. A common thing that's quite happens is I ask the patient to lean into the sensation, and when I can teach them specific skills to feel safe with the sensation, meaning that not to have the knee-jerk reaction of trying to push it away and trying to welcome, I just need this pain to go away. That tug of war in the mind tends to cause most suffering. And so what I tend to help my patients with, I try to teach them skills very specifically to feel safe, calmer with the sensations. And in of that process, they start to realize, even without changing their thinking about it's structural, not structural, I don't get into that battle. It's like trying to say I am this or that. I'm not trying to get into that argument. It's a futile thing for any clinicians to do. So what I do is I walk them through experiences, and when they get the relief, when they ask them to pay attention to is when they don't have pain as much, when they're laughing, and when they're feeling loved, when they're playing with their dog and hugging the dog. What do you notice about your pain? That's interesting. So that's what we do. Is I think it's very inhuman to try to convince someone to not feel something. It is not my responsibility. My responsibility is to provide the support. And I also want to be clear. I tell my patients, I do not have all the answers, but I'm confident in the work that I do. Even someone who claims that, my doctor said I have, great. Now, how does that serve you by hanging on to that belief? And if it doesn't, what I want people to do is, what would happen if fear was no longer a barrier to this sensation? And that's where I working off and trying to show them experiential exercises and skills. Try to show them that you collect the data, not me. Notice when you don't feel as much, and notice when you feel as much. Having a clear explanation of why do they hurt using modern pain science, showing them that there's a clear reason why the brain feels more pain when we're feeling life stressors.
Yes.
It's not psychological. It's both. it has a psychophysiology to it, or a mind body to it, or brain body to it. So it's not separate, it's part and parcel.
I've seen and heard you talk a lot about SIM and DIM, safety in me and danger in me. And I think that that's such an important distinction. And I just want to bring up really quickly off of this safety in me versus danger in me. So a lot of my audience, you know, I had scoliosis, childhood scoliosis, and I was followed every 3 months by orthopedists, by your forensic orthopedic physicians who, you're going in there, you're a child, most of us are children, adolescents, and you're, in some cases, like myself, watching your spine not do what it's supposed to do, which is grow, right? So we're growing and our spine is collapsing. And, you know, I think I got really lucky. My orthopedic surgeon was one of those very optimistic types. And he says, you know, it's getting worse. Let's go in there. Let's do a 13-level fusion. Let's get this thing stabilized. And then guess what? You're going to be good to go. Do whatever you want. Gave me no restrictions. And I think that is one of the reasons I have done so well, because I've heard other people who've had the same surgery, the same experience, whose orthopedic surgeon said, if we don't go in there, this spine is going to collapse your lungs. It's going to collapse your heart. Now, imagine getting that message as you're growing up, that your body is going to basically harm itself. Danger in me.
Right.
So I do think, so with my audience, many have had scoliosis surgeries, and some have fairly good outcomes like I have, and some have had chronic pain for years because of it. Yeah. But I do wonder if it's that safety in me versus danger in me. I remember at one point in time, I finally had to realize, even though my spine looks like danger in me, when I show it to you or someone else, I had to reprocess that as my normal, my healthy. Yeah. Had to reprocess it, which I think it's almost like I knew to do this instinctually before I really understood this work. So
yeah, I don't. Not many people are like you, Julie. So I think that's fantastic. The term DIMS and SIMS really is just a fun way of expressing what the nervous system is doing. Let me explain this. So the nervous system, and when I define nervous system, I keep it super simple. Nervous system is basically the brain and body and all the cables in between it, all the nerves. And one of the things I want people to know is this: the brain or nervous system, whatever is easier for you to digest this information, the nervous system is scanning 3 domains every half a second. Not a second. Think about how fast a second is. But every half a second, the nervous system is scanning messages inside of me, outside of me, environment, and whomever and whatever is in front of me. Inside, outside, in between. And it's constantly scanning these areas for one question to be answered: am I safe or not? Am I safe or not? Am I safe or not? And that's what the nervous system is programmed, or the brain is programmed to do, is it's in service of our survival. So let's walk through this in a simple manner. When I have a physical sensation or a difficult thought or difficult emotion, and if I don't know how to relate to it, I actually trigger biological imperatives to protect us. So the brain goes into automatic fight or flight. So when we have like, oh my gosh, this is really, when we start to do that and get drunk in the sensations and over-identify with the sensations, and you do not have skills to separate, well, Les, you don't understand, I have real structural, stop for a second. Let's just say you do have real structural issues. And you're like, you can't convince me that the mind has nothing to do with it. Great. Let's just say you believe that. Regardless of what that is, the source of it, when something gets programmed in the brain, what happens is we need to learn how to relate differently to it. And so regardless of the source of it, the question is, in this moment, If you're feeling freaked out about it and you're complaining about it, you're fearful about it, and you're trying to figure out how to get rid of it, you're fighting like as if you were in quicksand. And everyone knows this from Hollywood movies, that what happens to someone who fights quicksand is they sink into despair. What we teach in PRT, in mind-body skills, is to make full contact. So if you're in the quicksand and that's the sensation could be a thought, an emotion, or a physical sensation. And when you make full contact with the quicksand, you float until you can get someone to come over and with a stick and pull you out of it. Now, the point here is this, is danger me messages basically is when the nervous system of the brain scans inside, outside, in between. And by the way, the in between could be a human being that you're living with. It could be the job, it could be in-laws, it could be the kids, it could be the text messages, it could be emails, it could be social media. It doesn't matter what the in-between is. Basically, when any one of these three domains we tend to fight or feel overwhelmed with, the brain activates the fight or flight, which is what we call danger me messages. And then it's transposed and you feel an amplification of more negative thoughts, raw emotions, and greater pain sensitivity. Safety in me messages are the opposite. When we can acquire skills, this is what neuroplasticity is, we have the ability to not get rid of the pain in that sense. It's a way to kind of quiet it and desensitize it. And in that desensitization, sometimes about 80% of my patients feel a resolution of the pain, which means they get into pain recovery. So when we can create safety in me messages, when a negative thought comes up, just noticing that. When the environment is overly stimulating, can you pick a sound? I'll give you an example. One of my trainings that I do with my patients is a funny one because I discovered it by accident. Now, I used to ride motorcycles, and what was funny is, but when I didn't, the Harley Davidsons have this loud roar when they kind of rip by a car, and I used to get so irritated. But now, when I hear a loud roar in the environment, I imagine getting on the back of the bike and taking off with them. When you learn to relate differently to what bothers you, your nervous system changes, and safety in me messages results in less sting of the physical sensation. When you can learn to kind of realize that when you're triggered by someone's insulting comments or lack thereof support and love, when you can learn to recognize that you're feeling overwhelmed and learning to separate from your thoughts, emotions, and sensations, it's a skill set. You realize you start to create safety in me messages. Ultimately, the end goal of SIMS, safety in me messages, it's a skill set of training to change the brain, that's called neuroplasticity, into modes of safety, which calms everything down.
Yep.
Simplicity, when your brain is not so stressed, your body is not so stressed, which then results in less pain amplification.
Dr. Les, thank you so much. I feel like we need a part 2 where Zoom is telling me we have 3 minutes left, and I'm going to put some links in our description box where people can find you and find more about these resources. But I just want to leave with one question for you. We're filming this November 2023. We're about to end the year and go into 2024. What is your intention? 1, 2, 3 words for next year. What's your next stage in this work or in your personal life? Yeah. What's the next thing for you?
Absolutely. My next phase in 2024 is to actually enter more health systems than ever, to get people to have this treatment, pain reprocessing therapy, because it's costly, and a lot of people cannot afford these services. So goal is to enter various health systems so insurance can actually pay for this, and not everyone's trained in this. So that would be my heartfelt wish, and I believe we're already there. We're getting into different health systems, and we would like to get into every single health system. in the next 10 years. But for 2024, we've started to enter health systems, and definitely, hopefully, you can give us a link to Menda.health and to be able to see what insurances we take. But that is one of my big heart mission, and most importantly for now, personally and future, is to have greater peace within us and around us.